Good morning, everyone. This is Stephanie Baker, Senior Program Coordinator from Massachusetts. I'm involved in the care transitions work with the New England QIN-QIO. And I'd like to thank you for joining us today for our webinar titled Providing Equitable Care Across New England, Understanding the Unique Experiences and Needs of the LGBT Patients. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded and the presentation will be available within a few business days on the QIN-QIO website. The phone lines have been muted for the presentation, but we do ask that you please not put your line on hold. Also, if you just joined as these announcements are being made, please manually mute your line either by pressing *6 on your phone or using your manual mute button. If you have a question at any point throughout the presentation, please enter it into the chat panel to the right of your screen and make sure you send your comments to all participants. My colleague Lorraine will be monitoring the chat window and responding to your comments in real time. Please don't be shy. We'd love to hear your thoughts about what our speakers are saying and how you are addressing the needs of your LGBT patients. You will also have the opportunity to ask questions over the phone at the end of the presentation. Our learning objectives for this program are to recognize disparities that LGBT people experience in urban, suburban, and rural parts of New England, to describe the distribution of the LGBT population across the 6 New England states and nationally, adapt current tools and resources to better capture sexual orientation and gender identity data, and apply best practices to provide equitable care for the LGBT patients. As I shared during this call, we want you to use the chat feature so that we can hear from you. So please type in with questions and comments on the presentation, your initiatives and experiences, as well as what you might need some assistance with. Let's start by seeing who is on the call. Please type in your name, your role, and organization of the state that you are calling in from. I'd like to introduce our speakers today. Today, I am thrilled to have with us Sean Cahill. He is the Director of Health Policy Research at the Fenway Health Institute, and Timothy Wang, who is the Policy Analyst at the Fenway Health Institute. It is important to note that today's speakers have no conflicts of interest to disclose, and this webinar has been granted ACPE credits by the Connecticut Pharmacists Association for 1 contact hour. Pharmacists that would like to receive credit will need to complete an online evaluation and enter the code that will be presented at the end of the webinar. Please remember that this code will only be available at the end of the presentation and cannot be emailed after. And now, I'd like to hand it over to Sean and Timothy to get us started.
Thank you, Stephanie. And thank you to everyone for joining us this morning. This is Tim. And Sean and I are going to be talking to you today about providing equitable care across New England, understanding the unique experiences and needs of LGBT patients. So again, thank you for joining us this morning. So Sean and I both work at Fenway Health. We're a federally qualified health center right next to Fenway Park, if you're familiar with the area. We serve about 32,000 patients each year, half of which identify as LGBT, 4,000 transgender patients, and 2,200 patients living with HIV. We are a Ryan White Part C clinic, and we participate in a lot of HIV prevention and HIV vaccine research. And we also have our behavioral health integrated within our primary care. We also offer dentistry and optometry. And Sean and I both work in the Fenway Institute, which is specifically the research, education, training, and policy arm of the Federally Qualified Health Center. So today, this is our outline for our webinar. I'm going to be going over just some terminology, LGBT 101, and then I'm going to talk a little bit about the demographics and distribution of LGBT people across New England with some deeper dives into Massachusetts data. And then Sean is going to take over to talk about LGBT health disparities, both general and those relating to elders, as well as strategies to improve LGBT cultural competency. So we're going to start off with some terminology. I'm sure a lot of you are probably familiar with this already, but it's good to have a foundation. So sexual orientation is how people identify their physical and emotional attraction to others, and sometimes it can be helpful to think about it in these different dimensions of sexual orientation. So we have identity, which is, how you consider yourself, what terms you use to describe your sexual orientation, such as gay, lesbian, bisexual, straight. And then there's behavior, so who are you having sex with, and attraction or desire, so what genders are you attracted to physically and emotionally. So usually these dimensions align. So for example, a woman might be attracted to a man, have sex with men, and identify as straight, but that's not always the case. You can have, for example, men who identify as straight but also have sex with men. So here's just a quick list of terms people use to describe sexual orientation, and this is by no means an exhaustive list, but they're some of the more common terms that we see. So heterosexual or straight describes someone who's attracted to people of a different gender, so for example, a woman who is attracted to a man. Gay is usually used to describe men who are attracted to men, but it can be used generally to describe someone who's attracted to people of the same gender. Lesbian describes women who are attracted to other women. Bisexual are individuals who are attracted to both men and women. And queer is a term that's kind of been more popular in recent times. A lot of folks use it as an inclusive term to kind of describe a bunch of different sexual minority and gender minority identities. So a lot of folks will use queer instead of saying lesbian, gay, or bisexual. But this is just to note that language changes over time, so context is important. For a lot of older folks, queer was used as a derogatory term, so they have a lot of negative connotations with it. And then gender identity is a person's internal sense of gender. So do I consider myself a man, a woman, maybe a little bit of both, maybe neither. So it's important to distinguish that all people have a gender identity and all people have a sexual orientation, and they're separate from each other. So when we're talking about gender identity, we're specifically talking about the T in LGBT, which stands for transgender. And that means that the person's gender identity doesn't align with the sex that they were assigned at birth. Assigned sex at birth is usually determined by the doctor or the nurse when you're born, and it's based on physical sex attributes or, like sex chromosomes, reproductive anatomy, things like that. So, for example, if you are male assigned sex at birth, but you don't identify as male, you could be described as transgender. Some alternate terminology includes transgender woman or trans woman, and that's someone who was male assigned at birth and identifies as a woman. Transgender man or trans man is someone who is female assigned at birth and identifies as male. There are other terms like trans feminine or trans masculine, as well as terms like non-binary and gender queer, which are kind of terms that people use when they don't want to identify themselves on a binary gender that's based, male or female, kind of outside of that binary and existing more on a spectrum. So now we're going to talk about the demographics and distribution of LGBT people in New England. And we have some deeper data dives regarding Massachusetts data, since that's where we're from. And we actually just published a report on the demographics of the LGBT community in Massachusetts. So this is a graph that's actually from that report, and it shows the percent of the adult population of each state that identifies as LGBT. And you can see here that the 6 New England states are identified with the little arrows. So Vermont is actually the most LGBT state out of all of them. So congratulations, Vermont. Followed by Massachusetts, then Maine, New Hampshire, Connecticut, and then Rhode Island. So it's important to note that this data is from Gallop Daily Tracking Poll, which is a phone survey that's conducted almost every day. So this is from about a year ago. So we went back and looked at the Gallop Daily Tracking Poll data just about a week ago. So the numbers are a little bit different here, but I think the order of the states is still the same. And then we also went and found some BRFSS data, if it was available online from the state. So for Massachusetts, we actually see from our 2016 BRFSS that the adult population, 7.2% identifies LGBT compared to 5% from the Gallop Daily Tracking Poll. And that's kind of a trend that we noticed that the Gallop Daily Tracking Poll kind of underestimates the LGBT population in comparison with the BRFSS. We also see that with Vermont, 7% according to their BRFSS, 5.8 according to the Gallop. And then these numbers, New Hampshire 3.9%, Maine 4.3%, Rhode Island 3.8%, and Connecticut 3.9%, all likely underestimates. And just looking a little bit more closely at the Massachusetts data, so that 7.2% that you saw earlier is actually broken down to 6.8% of adults identifying as lesbian, gay, or bisexual, and 0.4% identifying as transgender. So when you add the two together, that's where 7.2 comes from. And also, we had some data analysis relating to specifically folks who are age 50 to 75 in Massachusetts. So LGBT people actually make up 4.2% of that population, and 9% of that population lives in Greater Boston, with 3% living in other parts of that state. So that's kind of about how LGBT people tend to concentrate in the more urban metropolitan areas. And this is kind of also, even though the percentage is concentrated in these urban areas, we wanted to really make the point that the LGBT population lives all across the state in every county, rural, suburban, and urban areas. So you can see that actually in 9 of the 14 counties in Massachusetts, the LGBT population is greater than 6% of the adult population. So certainly in areas you would expect, where Boston is, but also just across the state. And this is also a trend that we saw in Massachusetts, but likely a trend that also exists in all the other New England states and nationally, in that younger people are more likely to identify as gay, lesbian, bisexual, or something else. So you can see this is BRFSS data from Massachusetts by age cohort. So for those aged 18 to 24, 15.5% identify as LGBT or something else. And you can see that that number kind of steadily drops as you get older in age, down to 2.7% identifying as LGBT or something else for those aged 65 to 74. And that could be for a lot of different reasons, but I think mostly we attribute that to times now being a lot more accepting for LGBT folks, so it's a lot easier for people to come out earlier. And I think that also speaks to the fact that we're probably going to see those numbers, the 7.2%, from our BRFSS, that's probably going to increase over time as the environment becomes more friendly to LGBT folks. So now we just also wanted to make sure that we made this point for New England as a whole. So there's actually this really great interactive map that was developed by the Williams Institute at UCLA that's using census and ACS data that we're going to share with you now. So this data, this map, you can see if you hover over a specific county, you can actually see the number of same-sex couples per 1,000 households, as well as the percentage of them that are raising children. So as you can see for the entire New England area, every county, whether it's rural, urban, suburban, has same-sex couples. I think this county is probably has the least number of same-sex couples, and still 0.94 for every 1,000. Same-sex couples. So that goes to show you that, same-sex couples, LGBT folks are living everywhere in New England, in every part of the state, including the rural areas. And it's also important to note that this is same-sex couple data, same-sex household data, since it's based off the census. The census doesn't actually ask about sexual orientation, so this is the only way that we can get that data from the census. And usually that's an underestimate of the actual number of LGBT individuals in the area. So for example, in Massachusetts, it says that there are about 20,000 same-sex couples, which means 40,000 LGBT individuals. And according to our BRFSS, we have about 400,000 LGBT individuals. So the same-sex couple data is about 10% of the actual LGBT community. So this is an underestimate of the actual number of LGBT folks living in New England. And that's just a snapshot of it. And so now we're going to move on to talking about LGBT health disparities, and my colleague Sean Cahill is going to take over from here.
Thank you, Tim. Hi, everybody. It's great to be with you today. So I'm going to talk next about disparities. And what we see with the LGBT population is disparities in disease burden and chronic condition burden, We also see disparities in risk behaviors and disparities in access to care. So we know that LGBT populations have higher rates of tobacco, alcohol, and other substance use. Men who have sex with men, most of whom identify as gay or bisexual, but some of whom identify as straight, they're at higher risk of HIV and other STIs, sexually transmitted infections. Lesbians and bisexual women are less likely to get preventive screenings for cancer. There's some emerging research that indicates that there may be higher rates of breast and ovarian cancer among sexual minority women. This is not related to same-sex behavior, but it's actually related to higher rates of nulliparity, which means not having children. So many lesbian and bisexual women do give birth to children, but on average, compared to heterosexual women, they're less likely to give birth, and that's a risk factor for ovarian and breast cancer. Sexual minority women are definitely experiencing at least the same rates of breast and cervical cancer, but we know from the BRFSS survey in most states and some other data sets that sexual minority women are less likely to have mammograms and Pap tests. So if they do get diagnosed with breast cancer or cervical cancer, they may have a poorer treatment outcome because they're getting diagnosed later on average. We see higher rates of obesity and overweight among lesbian and bisexual women. Transgender people, particularly transgender women, experience higher rates of HIV and STIs. We also see higher rates of behavioral health issues like depression, social anxiety, and higher rates of suicide. And transgender people are less likely to have health insurance than heterosexual or lesbian, gay, and bisexual individuals. And in those disparities that I just described, we also see these sexuality and gender disparities intersect with race ethnicity disparities. So, for example, higher rates of obesity among sexual minority women intersect with higher rates of obesity among Black women who are mostly heterosexual. Lower rates of cancer screenings, we also see that among Black and Latina women. So those intersectional populations will be priorities in terms of public health outreach and promoting cancer screenings and diabetes and obesity screenings. Among older adults who are LGBT, we have a study that Karen Frederickson-Goldson did at the University of Washington. It was a national study. Boston was one of 10 sites, and actually our colleagues at the LGBT Aging Project helped recruit people for this study. And about half of the 2,500 people surveyed, age 50 or older across the U.S., had a physical disability. About a third reported depression. We saw higher rates of cardiovascular disease and obesity among sexual minority women, and poor physical health among sexual minority men. About close to two-thirds reported being victimized at least 3 times in their lives because of sexual orientation and/or gender identity, and about 1 in 4 were veterans. So just important context to understand in terms of health care. Now, it's important to understand the context of the lives of LGBT older adults. Many came of age, in other words, many were adolescents and young adults during a period of intense homophobia in our culture. So if you look at the early 1960s, homosexuality was criminalized in all 50 states. It was considered a mental illness by the psychiatric profession until 1973. So many healthcare providers encouraged their gay and bisexual patients to seek therapy to try to stop being gay or stop being bisexual. I have a friend who just celebrated his 50th anniversary graduating from Harvard, and he saw a classmate who in 1964, when they were freshmen, went to the infirmary on campus and disclosed his same-sex attraction to a healthcare provider and was referred for electroconvulsive shock therapy. So this person is now probably 72, 73 years old, but that was his experience with the medical profession. And that's important in terms of understanding medical mistrust with this population. Gender identity disorder was only removed from the Diagnostic and Statistical Manual in 2012, and it was replaced with gender dysphoria. But there's still a mythologization of transgender identities. And homosexuality was a legitimate cause for being fired or denied employment, losing custody of your children, until well into the 70s and 80s, and it's still a factor in people's losing their jobs today in certain parts of the country. So for many LGBT people, non-disclosure was a survival strategy, and so that's another important thing to understand, particularly in rural areas and in terms of getting people to disclose that they're gay or bisexual or transgender. And many continue to fear discrimination in healthcare and in senior settings, particularly senior living settings, but also senior centers, targeted meal programs. This is the front page of the New York Times in 1963. And it's a very interesting article that I've taught in classes that just gives you a sense of how different the world was when LGBT older adults were young and coming of age. And these were the kind of messages that they were getting. In this article, there's a very clear social consensus that homosexuality is a crime. It's a moral failing or a sin. All major religions consider homosexuality a sin. And it's a mental illness. And the goal is to somehow reduce and eliminate it as opposed to acknowledging it as just a variation in the human experience and accepting it and supporting it. This is an image from the American Psychiatric Association conference in 1972. And on the left are a couple of early gay rights activists, Barbara Giddings and Frank Kameny, who were advocating for the APA to delist homosexuality as a mental illness. And on the right is Dr. John Fryer, who was known as Dr. Anonymous. He was worried about losing his license to practice, but he wanted to speak out in support of removing homosexuality from the list of mental illnesses. And this campaign was effective, so a year later, the APA did delist homosexuality. Another thing just to know about in terms of the demographics of LGBT older adults is that many are single and or live alone. On average, they're less likely to have children and grandchildren. Some who have children are estranged from them. This is especially true now of transgender older adults. And so this may mean that LGBT older adults are more in need of formal caregiving support so that they can stay in their homes and age in place. Another concern we have with older adults who are LGBT is higher rates of social isolation. And one approach to reducing that and to helping LGBT older adults develop and strengthen social support networks is using Older Americans Act funding to support targeted meal programs for LGBT older adults and their friends. So this is a picture from a senior meal program in the Boston area for lesbians and their friends. So this provides nutritional support, but more importantly, helps people, usually on a once-a-month basis, get together with friends and develop and sustain friendship networks that can be helpful with, like I said, caregiving and other assistance. You know, if you need to go get a colonoscopy, you have a friend who can bring you and help you get home from that. So we now have 23 meal sites in Massachusetts. One that's not on this map from a year ago is Greenfield in the northwest of Massachusetts. These are really great. There are other states in the country doing this, and this is something we would encourage people in other New England states to take up. We're using existing funding streams to do this, and it doesn't cost a lot of money. Some of them, like the one on Cape Cod in Orleans, they have a once-a-month dinner and a movie night. I think it's on a Friday night. And so they have a meal plus a movie, and then people discuss the movie. The life experiences of LGBT older adults shape how they engage healthcare and support networks. So many LGBT people are veterans, despite all of the anti-gay and anti-transgender policies that we've had over the years, and still to this day in terms of transgender service members. So they often associate military service with prejudice. Many of them were dishonorably discharged, and some might not access VA health care or think that they're not eligible to access health care at the VA and other services like suicide prevention, housing assistance, employment assistance. So it's important to sort of encourage LGBT veterans to try to access the VA. There's a lot of good stuff happening at the VA, and I'll talk more about that in a bit. For many older gay men, AIDS decimated their social network, and that's a factor in higher rates of social isolation. And social isolation is an important health issue because social isolation can correlate with depression, with higher rates of substance use, and with poorer medication adherence, including HIV medication adherence. Another thing to know is that many older Americans as a group are more likely to hold anti-gay views, for example, to morally disapprove of homosexuality, or to believe that HIV could be casually transmitted by, a person living with HIV eating in the same dining room or using the same restroom. That's not true. You can't transmit HIV that way, but older Americans are more likely to believe that. And so it's important to understand that and to ensure that elder services are accessible to LGBT older adults, and that LGBT clients are not experiencing prejudicial treatment by their heterosexual age peers. Another health issue affecting this population is HIV. So HIV is not a gay disease, but it disproportionately affects gay and bisexual men and transgender women in the United States and around the world. So more than half of people living with HIV in the U.S., about 1.2 million people overall, about half of them, or maybe more like 60%, are gay and bisexual men or transgender women. They're disproportionately black. In Massachusetts, about two-thirds of people living with HIV are age 50 or older. We see high rates of substance use, including tobacco use, and also behavioral health burden among people living with HIV in general. And many of these people are now engaging senior service systems, entering nursing homes, and so that's an important population to understand. And we have some resources on our website that I'll mention at the end of the presentation to learn more about things you can do to improve the health of your patients or clients who are HIV positive. Here's some data from the Massachusetts BRFSS showing higher rates of depression among middle-aged and older adults who are LGBT compared to heterosexual cisgender adults in that age cohort. And these are some other differences that we found. We worked with our state health department here in Massachusetts, and they did analyses of the data from our BRFSS. They actually pooled a couple years of data to look at differences and found that there were similar rates of poor mental health and regular cigarette smoking, but higher rates of e-cigarette use and higher rates of marijuana use among the LGBT folks who are middle-aged and older versus heterosexual. So those are just important health issues to know about. And when you're screening for tobacco use, don't just say, do you smoke? Make sure you say, do you vape? Do you use e-cigarettes? Because a patient might say, no, I don't smoke, but they vape, and it's important for you to know that and talk to them about the risks of vaping as well as traditional smoking. Some of the correlates of higher substance use include family rejection, lack of social support, stigma and minority stress, which often involves anxiety related to disclosure. We, like Tim and I, are both out as gay men, but we navigate disclosure all the time on the subway, when we meet new people, and that can create stress in your life. Abuse, harassment, violence, victimization are correlates. Also, pro and anti-LGBT policies and policy debates. So whether it's the anti-transgender Gallop campaign that we had here in Massachusetts, which thankfully was defeated by about a 2-to-1 margin, or it's the debate over whether transgender people should serve in the military. Even just the fact that there's that debate, that can create stress and make people feel unsafe and make them question their sense of belonging in society. So here's a little bit more data on veterans. We found that among middle-aged and older adults, I think this is really compelling. Despite the anti-LGBT policies that have been in place, including the anti-transgender one today and the anti-gay, lesbian, bisexual policy that was in place until about 8 years ago, LGBT people are serving in the military at about the same rate as heterosexual cisgender people. So that's important in terms of helping them access the VA for health care. 9 million Americans get their health care through the VA system, and so it's important that LGBT veterans access that system at a similar rate and get the benefits that they have earned, by serving our country. Most veterans are men, but actually lesbian and bisexual women are more likely to be veterans than heterosexual women. So it's important that you talk to your older sexual minority women patients about this in particular. Like I said, about a quarter of LGBT elders in this national survey are veterans. The VHA is a large provider of health care. And there's a lot of good work happening within the VA, a lot of training of staff. There's directives to ensure that LGBT veterans and intersex veterans, which is a related population, another population, people who are not, whose physical genitalia or chromosomes don't fall completely on the male end or the female end of the spectrum. Maybe as many as 1 to 2% of the population is intersex. So the VA is also trying to ensure that intersex patients access health care. There's a need for affirmative outreach to LGBT vets, and veterans as a group have high rates of suicidality, and within that veteran population, LGBT veterans have even higher rates of suicidal ideation and attempts. So that's an important health issue. This is just an image of some older lesbian or bisexual women from the Boston area. Another issue is discrimination, particularly discrimination in healthcare. So this is a national survey that Lambda Legal did that found that more than half of LGBT patients and almost 3/4 of transgender patients experience discrimination in healthcare settings. We did a survey, which I'm going to mention in a minute, but the National Center for Transgender Equality did a national survey of about 28,000 transgender people and found high rates of verbal harassment, being physically attacked. So this is important context. When you treat a transgender patient, it's quite possible that patient has PTSD related to being harassed in a public space, being harassed in their neighborhood. There's high rates of poverty, unemployment, and homelessness, high rates of psychological distress, much higher rates in the general population, in the transgender population, and about 10 times the rate of suicide attempts. And then we did a study here in Massachusetts and found that about 2/3 of transgender people, we surveyed about 450 respondents, about 2/3 experienced discrimination in a public accommodation in the last year, and those who experienced discrimination had about twice the rate of physical and mental health symptoms like pounding heart, headache, feeling sad or depressed, and those who experienced discrimination in a healthcare setting were less likely to seek subsequent care. So that's a bit about the context. So what can healthcare providers do to improve cultural competency in the experience of care? One thing is that they can train all staff in how to provide affirming, culturally competent care. They can put up posters and pamphlets in the waiting room that depict LGBT people or same-sex couples. They can post a rainbow flag. It seems really simple, but this can really send a message that that LGBT people are welcome and that the staff are competent to serve them. Adopting a non-discrimination policy and training staff in how to uphold it is important. It's really a great teaching opportunity for staff. And then hiring from the LGBT community, especially the transgender community. We see high rates of unemployment, and if somebody walks in and there's a person at the front desk or a person who's a physician's assistant or a medical provider who is a transgender person or an openly gay person, that can send a message of welcome and inclusion as well. Thankfully, the Joint Commission has required that healthcare organizations have a non-discrimination policy as an accreditation criterion since 2011. And CMS has also required since 2010 or 2011 when this was implemented that same-sex partners be allowed to visit their spouse or partner in a nursing home or hospital that is participating in Medicare and Medicaid. Marriage equality also protects visitation rights for same-sex spouses. Now, thankfully, we live in a part of the country where all New England states have sexual orientation and gender identity non-discrimination laws that cover employment, housing, and public accommodations. But it's still good for institutions to have these policies, to use them to teach staff and to even publicly display them so patients can see that. It sends an important message to the majority heterosexual non-transgender patients as well. There's limited research on the experience of LGBT people in rural areas because they are less visible communities than, say, the gay community in Boston or the gay community in Burlington, Vermont. LGBT people may feel less safe disclosing their sexual orientation and gender identity to a healthcare provider in rural areas. But in spite of this, it's important to remember that LGBT people live everywhere. Like Tim pointed out, even in small towns and rural areas, we may be a smaller percentage of the population in rural areas than, say, in an urban area. But in some rural areas, like in many parts of Vermont, in western Massachusetts, near Northampton, there are definitely big LGBT populations. And one of the studies that we found, this is a study actually of mental health providers in New Mexico, in rural areas of New Mexico, but they found that LGBT clients experienced widespread discrimination when trying to access mental health care and substance use treatment at both the hands of both providers and heterosexual clients. So it's important to ensure that there's training available and on a regular basis given to staff and volunteers to ensure that LGBT patients can access these services. We had a man who reached out to us seeking an LGBT-friendly bereavement group because he had lost his spouse recently, his husband, and he reached out to a mainstream bereavement group and was told, yeah, he was welcome to come, but he should not disclose that he had a same-sex spouse. Well, that's not going to help him work through his loss, to have to be worried about people finding out that he's gay and responding in a hostile way. So it's important to make changes in behavioral health care as well as medical care. This is just a map from the Williams Institute showing the percentage of all households that are same-sex households by city and town in Massachusetts. So again, showing that it's not only in Boston, Worcester, Springfield, but it's all over the state where we see a high proportion of same-sex couples among all couples. There are just a couple of issues related to caring for transgender patients in particular. Frontline staff should follow a STEP protocol for noting preferred names and pronouns, for communicating with transgender patients. So something as simple as, instead of saying hello, sir, or hello, ma'am, when a new patient walks into the waiting room, but just saying, hello, may I help you? That can ensure that you're not going to accidentally misgender a transgender patient, which can, set off a negative experience for that patient. Having an appointed staff person who is responsible for providing guidance and assisting with procedures can be helpful, and ongoing training and retraining for staff on transgender competency is important. Identification wristbands for patients should show the patient's preferred name, pronouns, and gender identity. And even if a transgender patient has different information on their insurance card, that's important for billing purposes, but there's no reason why you can't use the preferred name and pronoun when you're interacting with that patient. We also think it's important to collect sexual orientation and gender identity data. And in a second, I'm going to mention some resources that we have online to assist with this. But this allows healthcare providers to better understand health disparities and inform interventions to address them. It's especially important that a provider know if they're treating a transgender patient so they can ensure that they're offering the right preventive screenings like prostate exams to a transgender female patient, breast and cervical cancer screenings to a male transgender patient. And perhaps the best way to collect this data is through a patient portal or a patient-reported outcome tablet because that's been seen as the most confidential way to collect these data. These are some questions that we've developed and that are actually encouraged by CMS and the Office of the National Coordinator of Health Information Technology. through the Promoting Interoperability program, formerly known as Meaningful Use. So that's the sexual orientation question. We also encourage you to ask, what is your current gender identity and what was your sex assigned at birth? That way you'll definitely identify transgender patients. And all of these things are important for a healthcare provider to know, and so we have our client registration form, which collects all of these things. And it's important to ask open-ended questions to allow patients to feel comfortable, and also to let patients know that you're asking everybody these questions. Sometimes people might get defensive and say, no, why are you asking that? And if you say, we ask all our patients their sexual orientation and gender identity, just like we ask all of them their age and their race, ethnicity, and their income, that usually tends to reassure people. So the final thing is just to mention some resources. We have a training available at the CMS Learning Network, the Medicare Learning Network, on how to collect sexual orientation and gender identity and use it to improve quality of care. The National LGBT Health Education Center has a myriad of resources that could be helpful for you in training your staff. They're all free, and you should try to access them. This is their website. This is a project of the Fenway Institute, and a lot of the content there Tim and I have actually developed. That includes this issue brief on strategies to improve the health of older adults living with HIV. It also includes a webinar on this topic. And actually, we have some materials in Spanish, in Chinese, and in other languages, how to collect SOGI data in Spanish and Chinese, but also how to provide transgender health care in Spanish and so on. And I think we're trying to move through some of the other languages like Haitian Creole and Portuguese that we see a lot of here in Massachusetts. This is a general issue brief, understanding the health needs of LGBT people. We also have specialized topics like how to provide affirming care to LGBT farm workers, migrant workers. This is a website we have called doaskdotell.org, which is a toolkit for how to collect SOGI data and use it to improve quality of care. We did this with support from the Robert Wood Johnson Foundation. And then we also have an aging commission here in Massachusetts that I serve on, and we put out a list of recommendations for how to improve elder services for LGBT older adults, and I would encourage you to take a look at that and feel free to share that with your elder services department in your state. Encourage them to reach out to us, and we'd be happy to talk to them about some of the issues we raised there. So thank you. I'm now going to hand it back over to my colleagues, and we look forward to your questions.
Great. Thank you so much, Sean and Tim. That was a wonderful presentation. And so, as we said, we'd like to now open this up for some discussion and questions. As a reminder, if you would like to ask a question over the phone, to unmute your line, you would press #6. And while we're waiting, Lorraine, I think I saw a couple questions in chat.
Yes, thanks, Stephanie. We got a question from Petra, and can you tell me if there are specific ways to help veterans who identify as gay or bisexual to improve their access to care? I know that you touched a little bit upon it, but I was wondering if you could elaborate a little bit further.
Yeah, absolutely. I would encourage, let's see, first of all, I would, we offer veteran support groups here at Fenway Health, and I know that the Boston Veterans Hospital Veterans facility and the Bedford, Massachusetts facility also offer LGBT support groups. I think there's a transgender veteran support group, and those allow people to just come together and sort of talk about sometimes their experiences as service members, sometimes their experiences trying to access services now. So that's one thing that you could see if that exists in your area. Another thing I want to mention is that there are two individuals who are national ombudspersons or liaisons for LGBT veterans. One of them is Michael Koff, who's based at the Houston VA. His last name is K-A-U-T-H. K like Catherine. And then, but the other person is Jillian Shippard, S-H-I-P-E-R-D, and she is at the Boston Veterans Hospital on Mission Hill, and she's the other liaison. And so if anyone has any trouble accessing VA services, they can reach out to Jillian Shippard or Michael Koff, and they should be able to refer them to someone who can help them locally or go to bat for them within the VA system. But I would, so that, anyway, I hope that's helpful. There may be other things that people can do, but those are just two that I can think of.
Great, thank you. We also had another question from Elizabeth. For institutions of higher education that are preparing future healthcare professionals, what should graduates entering practice or residency ideally have an understanding in terms of caring for LGBTQ population?
That's a great question. I would refer you to a couple of resources. One is at the American Academy of Medical Colleges, or the Academy of American Medical Colleges, has put out a curricular guide. They put it out maybe 3 years ago, and it's basically a guide for what medical students and other healthcare professionals should be learning in graduate school related to LGBT health, disparities, et cetera, but also how those schools can improve their teaching of LGBT health concerns. So I think that that the LGBT health issues should just be integrated into the curriculum, along with, racial ethnic disparities, issues related to serving patients for whom English is not their first language, who may have limited English capacity, which we see especially with a lot of older immigrants. So that's one resource. The other resource is Fenway Health has put out a medical reference guide called the Fenway Guide to Lesbian, Gay, Bisexual, and Transgender Health. We published that guide with the American College of Physicians, and that's available on our website, on ACP's website, for purchase. It's like I think it's $50. So it's the only thing that we charge money for. Everything else is free. But that may also be beneficial because it has chapters on, transgender health care. It has chapters on LGBT youth, LGBT older adults, sexual minority women, sexual minority men, sexual health for gay and bisexual men. So it goes into a lot of the details. I just want to correct one thing I said about the VA. I just want to give you Jillian Shippard's name. Her last name is Shippard. It's S-H-I-P-H-E-R-D. And her first name is Jillian, J-I-L-L-I-A-N. But she's the person you should reach out to at the Boston VA if you have a patient who's having trouble accessing VA benefits and services.
Thank you so much. So I have two similar questions that came into the chat about your written materials and their availability in multiple languages. So can you just talk a little bit more about, are all of your resources in multiple languages, and how would people access those resources?
Yeah, they're not. The vast majority are available only in English, but some are available in Spanish, and I think there's one document about collecting sexual orientation and gender identity data that's in Chinese. So I think our goal is to make more things available in other languages, but we don't have a plan to translate everything into Spanish and into Portuguese and into Chinese. That's not our plan. But I think going forward, we're going to try to do more in languages besides English.
And I think a lot of it is the ones that we do offer in different languages are on how to ask the question.
Right.
Specifically, so it's like a standard translation of how to ask a patient their sexual orientation and gender identity.
Yeah. But I know there's one document about how to provide affirming, culturally competent care to transgender patients, and that's in Spanish too. So like Tim said, it's mostly about how to collect the data and use the data and use the language that people understand. Because like in Spanish, there wasn't necessarily a word for heterosexual. People would just say like normal. That normal was heterosexual, and so we tried to figure out ways to ask the question in ways that didn't confuse people. Because there's some research that indicates that Spanish-speaking immigrants and Asian immigrants there were higher non-response rates when you ask those questions of them. So that's one reason why people have been translating into those languages and cognitively testing the questions.
Great. Thank you. So I just want to check, is there anyone on the line that would like to ask a question? And if you do want to ask a question, you can hit #6. Okay. I do have another question for you that came in from the chat, and it's a specific question that asks from Bernice. Do you refer to someone who does not want to identify with a specific sexuality queer?
I think that is a way that a lot of people use the term queer now as like an umbrella term that's more inclusive, so people don't have to necessarily label themselves gay, lesbian, bisexual, or something like that. A lot of people will just say queer. I wouldn't necessarily recommend just calling someone queer if they don't like identify with another sexuality, because again, as we talked about earlier, language changes over time, and queer still has some negative connotations for some folks, so you don't want to accidentally offend someone by just calling them queer. So I think that for a lot of younger folks, that is how they are using the term, but I would probably advise against just calling someone queer unless they already refer to themselves as queer.
Yeah. Somebody who's not sure their sexuality would probably be questioning. Like that's another, when you see the Q, especially with youth, a lot of times with young people, adolescents and young adults, the Q stands for questioning. In other words, they're still kind of figuring out their sexual identity or who they're attracted to. But queer tends to be more something that young people use than older people. So if your patient population is primarily, or your client population is mostly middle-aged and older people, I would only use the word queer if somebody self-identifies that way, you know. But some people get offended with that term. I personally don't have a problem with it, but I don't have a problem with homosexual, because I think it's, but, you know, a lot of people think that's stigmatizing, so they prefer gay, you know. So. There was a question about, oh, go ahead.
No, that's okay. Shantan, this question, I think, just kind of rolled right nicely into where you were going in a moment ago. Can you speak to healthcare disparities and concerns specific to the LGBT youth population?
Yeah. I will, and then I'll let Tim talk. Tim serves on the Massachusetts LGBT Youth Commission, which I used to serve on. You know, the issues that we see, first of all, it's important to understand this is a huge population. So in Massachusetts, on our behavioral risk factor survey, among 18 to 24-year-olds, 15.5% identify as LGBT. So that's like 1 in 6 or 1 in 7 are identifying as LGBT. And then on our youth risk behavior survey, which is a survey of high school students, 15% are LGBT, and that includes youth who identify as gay, lesbian, bisexual, and also youth who are engaging in same-sex behavior but don't identify as gay. That's altogether, that's 13% of the youth population, and then 2% identify as transgender. So this is a big population, I would say a lot of the health issues they experience are the same that all adolescents and young adults experience, but you know, with gay and bisexual male youth and transgender female youth, HIV and STIs are a big concern, particularly among Black and Latino youth. We see very disproportionate burden of HIV, syphilis. So sexual health and educating them about how to protect themselves using condoms and lubricant is very important. Also just sort of helping them get information about sexual health. We have another project that we're doing with colleagues at the Centers for Disease Control, and a lot of young people don't know where to get information, and they're not getting it from healthcare professionals. They're not getting it from sex education class in school. They're getting it online, and it's not always from the greatest places. So that's important. Also, behavioral health issues, anxiety, depression, higher rates of suicidality. We see 5 times the rate of suicidality among LGBT youth versus heterosexual youth nationally and in Massachusetts. So about 5% of all youth are thinking about suicide or attempting suicide, whereas 25% of LGBT youth, even in a very liberal state like Massachusetts, where we have a lot of resources for LGBT youth, we continue to see that disproportionate burden. Another issue we see is disordered eating. So higher rates of dieting, taking diet pills, bulimia, anorexia, particularly among gay and bisexual male youth and among transgender youth. And with transgender youth, sometimes it'll involve dieting. We've heard of gender variant youth who are approaching puberty who start to diet, trying to stave off puberty because they don't want to develop secondary sex characteristics, or youth who've gone through puberty who overeat to cover up those characteristics. So those are important issues for pediatricians and adolescent providers to know about. If you're seeing that with a lot of your sexual and gender-minority patients, it's not an accident. There actually is disproportionate burden. And a lot of those topics are covered. There's issue briefs and webinars on the LGBT health education website about those youth health issues. Do you want to add anything to that?
Sure. And just as Sean said, I'm on the Youth Commission, so we have 3 main areas that we're looking at to tackle with LGBT youth. And Sean talked about one of them, which is just it's sexual health, but also health in general. So the sexual health disparity Sean talked about, as well as the behavioral health burden. And then the other 2 areas that we're really focusing on are bullying in schools and homelessness. So in school, there's data, the GLSEN School Climate Survey that comes out, I think, every year, every 2 years, collects a lot of data on bullying of LGBTQ students. And we see higher rates of verbal harassment, as well as physical harassment, sexual harassment against LGBT students. So that's definitely something that is an issue that we're trying to look into, and some strategies for combating that are, starting GSAs in schools, so gender sexuality alliances or gay straight alliances, and also just having more inclusive curriculum that includes topics related to sexual and gender minorities is really important for people to feel affirmed and like their identities matter. And then for homelessness, you see increased homelessness with LGBT people in general, but also LGBT youth, and a lot of that has to do with being kicked out of your home, from families who aren't accepting. And so that's also an issue, and also the intersectionality with that and race ethnicity is also something that we see a lot too. So those are just some of the issues that the Commission is working on.
Great. Thank you so much, Sean and Tim. I'm going to turn this over to my colleague Stephanie to wrap up this amazing webinar. And for those of you that had questions still left in the chat, we'll make sure that we try to get those answered for you. Stephanie?
Yes, thank you so much. What a great discussion. Sorry that we have a few questions left, and as Maureen said, we will make sure to touch base via email afterwards. For those pharmacists who are claiming continuing ed credits, the ACPE code is LGBT, and as a reminder, you will not be emailed this code after the presentation, so please write it down now, and we must fill out the online evaluation. And I'd like to thank the New England Rural Health Roundtable for co-sponsoring this webinar with us, and to remind everyone that we are on social media, so check us out on Facebook, LinkedIn, and YouTube. And finally, if you would like to reach out to our contacts in the individual states, here is everyone in the states and the email address, so please reach out to us and ask any additional questions. Hope everyone has a wonderful Thursday and enjoys the nice weather we're getting. Thank you. Thank you, Sean and Tim.
Thank you.
Mm-hmm.